So the problem, so British Columbia is a vast province. I looked this up a couple days ago. So we're the same size as France, Germany, and Netherlands combined. We are larger than Washington, Oregon, and California combined. Yet we have a much smaller population, about 4.4 million people in 2010, but spread out over a much larger area. It takes 2 hours to fly halfway up the coast. That's just halfway, not even all the way to the north of the province. And I looked on Air Canada last night. It costs about $900 a person just to get there. Now I remember from one of Kathy's slides that that's how much it costs to get someone, a psychologist, for 6 sessions. In this province, that's how much it costs just to get you in the front door. And some areas, of course, are inaccessible during inclement weather. One of the communities we served last week, they were sitting at a balmy minus 27 degrees Celsius. And you know, for example, for Prince Rupert, the airport sits on an island that is only accessible by ferry. And because it's on an island in the northern Pacific, if the waves are high enough, you basically cannot fly out of that site. Jets don't go there, you have to go there by turboprop. And in other areas, like in the very far northern reaches of the province, which are about the same latitude as Alaska, the only way in there is through bush plane or by snowshoe, basically. The other problem is that we're under-resourced. So in this province, we're actually quite fortunate that we have a universal system of mental health teams that provide child and youth mental health services to children and youth all over the province. And these are funded by the Ministry of, the Ministry of Children and Family Development, not by the Ministry of Health. And so in every community, basically over a population of about 1,000 people, you'll have one of these mental health teams. The larger your community, the more likely it is to be staffed by more specialized people. So for example, in Vancouver, you're likely to have a staff of several psychiatrists, psychologists, social workers, and nurses. If you're in a very remote area, you'll probably have some social workers and mental health clinicians. If you're in a very, very remote area, you'll be lucky if you have an itinerant person that comes in every few months. So highly specialized care, though, in this province is centered in 3 communities. The one that you're sitting in right now, Vancouver, also in Victoria on Vancouver Island, as well as Prince George, which is situated sort of geographically in the center of the province. Traditional outreach services are rather scarce. Basically, you have to fly in a specialist, and that happens maybe once every 3 to 6 months. It's impossible during the winter for some communities, and most communities just receive nothing at all. So our solution to this problem is that we are integrating telehealth or mental health solutions into the regular workflow across all of our mental health programs without exception. And so this is just a brief overview sort of what we have. So we have a full range of services ranging from the emergency to the non-emergent. We have an emergency psychiatric service that can be accessed Monday to Friday between 9 and 5. And that response time is within minutes to an hour. And that allows an ER physician anywhere in this province to access an emergency child and adolescent psychiatrist here at Children's simply by dialing in. And then we can see that person and assess that patient and determine whether they need to be flown here to Vancouver. We have an urgent service, so we have a telephone service. And this is actually not just for psychiatry, this is across all medical specialties. There's a toll-free number that you can call. And basically you can reach a cardiologist, a dermatologist, psychiatrist, whatever you need. And it's for primary care practitioners such as GPs, but really any specialist, any physician can access this service. And the time frame for that service is usually up to 2 hours, but usually the response is within a few minutes. And that's for really brief telephone advice. For example, the typical call that I might receive is that, well, you know, I have this patient in my office right now and they're suicidal, what should I do? Or I have this patient in my office and they're telling me a lot of sort of paranoid things, what should I do with that person? Then we have an urgent assessment clinic, which sees people within days to weeks. And that's an outpatient clinic, and that provides psychiatric assessment as well as limited follow-up, usually around, say,
1 to 3 sessions.
Yeah, up to 3 sessions.
But assessment is always.
Yeah, so really we're trying to return people back to their local community for treatment. And then we have non-urgent services, so inpatient and outpatient services. our inpatient units have been fully telehealth enabled, so that they're doing all their pre and post-admission care via telehealth for anyone that's referred from outside the local city. They're doing family therapy, they're doing case conferences, the social workers are meeting with families. All of that is video conference. And then in terms of our outpatient services, we sort of split them down into tertiary levels, so those are the highly specialized clinics that only exist in Vancouver, and then a secondary level service, which kind of takes the place of the fly-in traditional outreach. And we're proud to say that with the secondary level service, or our outreach program, that we can see people within days to weeks, which, for those that are familiar with the system here, means that we can actually see somebody that lives 1,000 kilometers away faster than someone that lives 4 blocks away from this hospital. So what we're going to do is do a little case study. We're going to describe our outpatient services and how exactly we enabled ourselves to do all of this. So the first step, and I hope this answers the question of one of my colleagues here in the room, is we decided that if you force people to go to a boardroom or to a special teleconference suite to do telehealth, it's already game over because people won't do it. Clinicians have very limited time. They see large caseloads, and they do not want to spend the time to break up that workflow and go to a separate room and log in and run the equipment. So what we did is we, through our partners in the government, have deployed desktop video conferencing technology, basically blanketing our entire department with video conference so that anyone can sit down at their desk and do a teleconference with anybody in the province. And this is a secure system. It's encrypted 128-bit AES for those that care. And it can reach out to any similarly enterprise-grade telehealth system, actually in the world. I can dial up a traffic cam in Oslo, for example. And as long as I have the IP address, I can do so from my desk. The technology works on standard PCs that are deployed throughout our clinics. It also works on laptops, and most recently I tried it on iPad, and that works as well. There's a number of different providers of this software. Cisco used to have a lock on this market, but now I see that Polycom has developed a desktop conferencing solution, and Microsoft, having recently purchased Skype, is also probably going to be deploying some type of enterprise-grade solution in the near future. So this was really a game changer for us because up until this point, we really were asking people to go into a separate room to do this work. And now, for example, I can just sit down at my desk, see a telehealth patient, and then turn off the screen and then see a regular patient, and then go back to seeing a telehealth patient all the same go, while accessing the electronic records using my iPad and seeing all the recent lab results on my iPad. And so I'm going to turn this over to Deb to talk a little bit more about the nitty-gritty details.
Yeah, I'll share with you what we've been doing in outpatient psychiatry here. So we have been developing guidelines for telehealth use to support our physicians and clinical staff to use the technology just as part of their general practice, so that there's no add-ons really, that we're using it as part of our regular everyday assessment practices. As part of that, we've developed criteria for clinical suitability, so including things like, is this patient potentially aggressive? Is there any risk to the technology in the room? And do they have a support person who's available to attend with them, particularly that given that many of these patients we haven't met before, and they've just been referred to us, and this is our first time seeing them. So that we want to just make sure that we've got some assurances that they're an appropriate client to be using this technology with. As part of that, we've also developed safety protocols that ensure that if there's an emergency that happens at the endpoint where that person is being seen, that we have standards that we follow to make sure that they're safe on their ends should there be any risk identified. And for our staff, we've generated a workflow and work standards to ensure that our telehealth system is user-friendly for staff, especially for some of us who aren't as technologically competent as others.
Just to get a sense of why we need that, to give you a sense of the acuity. So we do see patients that are actively suicidal. We do see patients that are actively psychotic, and I've had to commit people to hospital via telehealth. after seeing them and realizing how ill they were, basically signing a mental health act certificate, faxing it out to the community, and asking the police to convey that person to hospital.
And so we're offering this service to patients and families who live outside Vancouver and are referred to our programs. And again, we're avoiding a parallel system or a standalone clinic, and just it's embedded in our work. Our plan and goal is for this to be family-centered care, in that we offer the families the choice to either make a face-to-face visit with us or to use telehealth if there's other barriers and obstacles to come to Vancouver, which many families actually prefer. The benefits, of course, are that we provide access. It provides access to psychiatric care for people living in underserviced and remote communities. It saves money and time for families in terms of travel and time off from work and childcare. And it saves money and time for the healthcare system in terms of fee premiums, reduced use of expensive emergency and inpatient resources. And it builds local capacity for our work in our teaching clinics.
So, I mean, with that last point, what we have is we actually have clinicians here, specialists in the field, such as infant psychiatry, that do educational seminars, for example, with community mental health clinicians and providers to sort of bring them up to speed with what the latest research is, what the latest techniques are for infants. And we have an entire sort of education arm of telehealth that isn't really described in these slides, but the Kelty Mental Health Resource Center. And so they have, for example, teleconferences, a few per month that reach out to hundreds of families and parents all over the province to teach them things about things like eating disorders, or what's the newest thing about marijuana? Does it cause psychosis or not? What about crystal meth? So these parent seminars, as well as like webcasts and videos on their website.